Okay, so let's do this together. So question says a 20-year-old college basketball player collapses during a game, looks very classical, cannot be resuscitated. Okay, autopsy reveals marked thickened interventricular septum. This is again what we just discussed, you remember? And left ventricular free wall with no evidence of coronary artery obstruction. So this is important. There is no coronary artery obstruction, okay, but the interventricular septum is thick. Histology of myocardium, now we did the biopsy, shows pronounced myocyte hypertrophy, disorganized and haphazardly arranged muscle fibers with interstitial fibrosis. Father died suddenly at age 35 during strenuous activity. Similar thing happened. So they're telling us it's running in families, it's hereditary. Which of the following best explains the underlying pathogenesis of this patient's cardiac findings? So what has happened here? And I specifically gave you this question so that you can again see how they describe. I believe you all figured it out. So this is hypertrophic cardiomyopathy. Okay, so this is HCM, of course, but what I want you to focus on is classical description, players suddenly collapsing on the field, athletes collapsing on the field, uh, and you probably, some of you would have seen this happening in a live basketball or football match or somewhere, and I have seen this once happening. And as soon as I saw it, like the person collapsed and died, and of course the autopsy report came, 2 to 3 days after. But I already had sort of thought of, this looks very classical of hypertrophic cardiomyopathy. Okay, and there are two words, hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy. So I'll talk about when we use those two descriptive words. Very important for you to now focus on a few things is markedly thickened interventricular septum. This is what I told you. So this is what is different from hypertrophy happening in a heart due to hypertension versus hypertrophy happening in a heart in this person. This is probably a case. Most of these are cases of genetic mutations. We'll talk about the genes. If you some of you know that gene, that's the beta myosin heavy chain gene. Remember? Okay, so that gene is the most often mutated and what causes hypertrophic cardiomyopathies. Okay, so this is one feature that you should always remember. Another thing, histology. So biopsy findings very important here. Again, I'll give you a reason why. Histology of myocardium shows pronounced myocyte hypertrophy. So pronounced myocyte hypertrophy is a feature in this hypertrophy which is common with hypertrophy due to hypertension. So hypertensive hypertrophy versus hypertrophic cardiomyopathy has one same feature. What is that? Of course, both are hypertrophy. So myocyte hypertrophy and the size would have increased. The difference is this is disorganized. This is such an important word here, disorganized and haphazardly arranged muscle fibers. In hypertrophy, due to hypertension, there is no disorganization, there is no haphazard arrangement. Okay, in that case, it is concentric hypertrophy arranged evenly. In this case, it is no concentric even arrangement. This is disorganized and haphazardly arranged. So this is what makes it, you know, interesting, and this is how you differentiate between the two types. Okay, I can promise you this is an important question all over your q banks. If you look at these questions, and it confuses a lot of us, when we are looking at questions. And interstitial fibrosis, again, whenever you have hypertrophy for a very long time, chronically, hypertrophy does lead to interstitial fibrosis. So again, fibrosis is a common one wherever you have hypertrophy, but the difference again is disorganized and haphazardly arranged in this case. And the location in this case is interventricular septum versus in hypertrophy due to hypertension. What is the location? All over the left ventricular wall. Okay, it's evenly arranged. In this case, it isn't. It is not evenly arranged. Okay, so these are the explanation to your answer choices. So A is deposition of misfolded transthyretin. So transthyretin misfolding and deposition in the myocardium is a type of amyloidosis. Okay, Inherited mutations in cardiac sarcomere protein genes. Yes. Okay, this is the answer. And which of the one is the most important one? One of the sarcomere protein genes, which is very important, is the beta myosin heavy chain gene. Okay, I have mentioned it here, so you can sort of learn this name. Chronic pressure overload because of hypertension? No, this is what I explained. Okay, that would not lead to disorganized and haphazardly arranged muscle cells. It would lead to hypertrophy, evenly spread out all over left ventricle, but not this one. Okay. What about option four? Inflammatory infiltration, recent viral infection. That is myocarditis. You remember last week we looked at that question. So viral infection with a lot of lymphocytes causing myocarditis and further causing dilated cardiomyopathy. This is different. This is hypertrophic. Option E says diffuse subendocardial ischemia with contraction band necrosis. Contraction band necrosis is a feature of when do you see it's reperfusion injury. You remember, we can talk about that next, but we did mention this in one of our previous lectures. Reperfusion injury, when you reperfuse, when you know thrombolize a clot, right? You remove a clot, you dissolve a clot, you use some thrombolytic drugs, remove a clot, restore the blood flow. When you restore the blood flow, okay, the patient already had ischemia, okay, and probably had some started on with some of the cells dying and infarction would have started. Patient came to you and you thrombolize. You want to remove the sort of clot and restore the blood flow, isn't it? That's what you would do, but the blood that goes back into the necrotic and ischemic myocardium causes even more damage. Okay, why more damage? Because of free radicals. So that is another MCQ they have asked you repeatedly, and they would ask you why more damage. So I gave you the answer: because of more free radicals, complement proteins, calcium. Inflammatory cells basically went back into that dying sort of myocardial area, ischemic myocardial area. Okay, so that causes more injury. So does that mean you would not reperfuse? We do that, but we have some more drugs to sort of take care of the cardiac function. Even if it initially causes more injury, we want to save the person's life first. Okay, so we can talk about that in another topic. So all these five options are pretty interesting, and they you know come from all five interesting topics and very high topics.